Hi, everybody. Welcome. We'll get started in just a moment. How are you, Blair? How's it
I'm
going?
good. How are you?
I'm good. Everyone just missed your co-presenter.
Oh yeah, well they're all kind of gathering.
Oh, they're very excited about tonight's presentation. They heard how amazing it was last night, and they are like, "We are here for round two."
That's right. Well, this is Ashy. Ashy's the one that came into it last night. So he was
Oh,
the
well, they're ready for part two. So, well, without
one
further
part
ado,
two.
I know you have so much information to cover tonight. So, welcome everybody to tonight's Wu University event, Oral Pharmaceuticals and Primary Care Optometry Part 2 with Dr. Blair Lonsberry.
Hello, everyone.
I'm your host, Dr. Jennifer Stewart. Just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to OE ARBO with OE tracker numbers. Tonight, there will be a QR code at the end of the event. So if you have the OE tracker app on your phone, you can also do that. If not, CE certificates will always be mailed within 4 weeks. And please ask questions using the Zoom on-screen floating panel. You can find Q&A and chat on your mobile device as well. It's my great pleasure to once again, twice in a week, introduce Dr. Blair Lonsberry. Grew up in Rossburn, Manitoba, Canada. He obtained his optometry degree from the University of Waterloo in 1996 after completing a Master of Science in Physiology from the University of Manitoba. He completed his residency in primary care optometry from the Illinois College of Optometry in 1997, then joined the faculty at Southern College of Optometry in Memphis. During his time at SCO, he completed a master's in education degree with an emphasis in adult learning. He's currently a full professor with Pacific University College of Optometry in Oregon, where his primary teaching responsibilities are supervising interns and overseeing a specialty lumps and bumps clinic. In his spare time, he goes to Anchorage, Alaska, where he sees patients in a private practice. And he has 2 white German Shepherd dogs named Bo and Bennett who keep him sane, plus 4 house guests for now,
Correct.
who will join in probably later. He's a diplomate of the American Board of Optometry, a fellow of the American Academy of Optometry, the Optometric Retinal Society, and the Optometric Glaucoma Society. With that, I will once again turn it over to you. If part 2 is anything like part 1, we're in for a great treat. So
Thanks,
welcome
Jen. I
again to Woo You.
really appreciate it. Thank you. Welcome, everyone. So I do speak for these various companies. All my financial relations have been mitigated, and we are going to be interactive. So if you wouldn't mind logging into my poll everywhere. So the quickest way is just with your phone, just click on the QR code there that should log you in. You might see a question running already. And if you were with us last night, I had a lot of slides and I thought I pared them down for tonight, but looks like I have actually more slides than I did last night. But I'm going to try to kind of cherry pick the good stuff tonight. So hopefully we'll leave some time for some questions at the end. All right, hopefully I have a few of you logged in. When the questions come up, the QR code should be up in the right-hand corner if you want to log in that way. So this is oral pharmaceuticals and primary eye care, part 2. That's my email address on the bottom there. So blonsberry@pacificu.edu. If you want a copy of my handouts or my lecture presentations, or if you have any questions, feel free to email me. I'm happy to answer those questions for you. If you did email me last night, I'm sorry, I had a pretty crazy day today, so I didn't get a chance to answer many emails, but I promise I will get to those. Let's start off with acne rosacea. So I was actually talking to my students, my interns, about this today. I did a lecture on dry eye with them. And one of the things I think we overlook a lot in patients is the chance for acne rosacea, and that being a cause for the dry eye. We know that acne rosacea is much more common in women, particularly that European descent, but it's much more disfiguring in males. So males tend to get them more aggressively. They tend to get the rhinophema on their nose and likely have more scarring involved with it. 85 to 90% of your patients with acne rosacea are going to have the ocular manifestations along with it as well. And when I talked to my students this morning, I said, what's the key thing that you want to look for? It's really those telangiectatic vessels that come up from the front part of the lid and go over back. If you see telangiectatic vessels, you really have ocular involvement, and your patients are likely going to be symptomatic of dry eye. We do know that Demodex is a big player for this, and there's 2 forms of Demodex. There's the follicularum plus the brevis form. And what we used to think of as staph blepharitis, which is the collarettes around the base of the eyelashes, that's really now been confirmed to be Demodex. And we traditionally have plucked eyelashes out and put them underneath a microscope for, people to see the Demodex. If you really want to kind of prove that they're there, you really don't need to pluck the eyelashes. All you need to do is really grab at the base of the eyelash and twist, and you can see that it backs itself out. And we twisted a couple times, and there's actually a second one there as well. If you really want to creep your patient out, you can tell them when they come out in their lids at nighttime and breed, which means that your patients will probably never sleep again. So management of acne rosacea, first off, is to try to make sure that they're avoiding any of their triggers. The unfortunate part for triggers for acne rosacea is that, frankly, being alive is a trigger for acne rosacea. So UV exposure, hot liquids, spicy foods, heat in general can all be triggers. And those can be really challenging for patients to kind of avoid. So we want to intervene it earlier if we can. And so things like omega-3 supplements have thought to be beneficial for patients, hypochlorous acid potentially to treat the bacterial component that might be along the lids, also maybe have some effect on Demodex. Now that we actually have XDEMVY in play for treatment of Demodex, that's really where we're going right now to address the Demodex component. And Demodex is a big trigger for acne rosacea. Just a reminder on XDEMVY, this is from Tarsus. It is indicated for the treatment of Demodex blepharitis. I have had a few patients that I've treated. I had one that literally was 4+, like every eyelash had Demodex on it. After two weeks of XDEMVY treatment, they were all gone. Now, the likelihood is that they're going to come back. Demodex is a natural part of our body flora, but what we're trying to do is prevent that excess number of Demodex that are there that's likely causing the problem. In my lumps and bumps clinic, I tend to associate Demodex with hordeola and chalazion. A lot of patients I see that have chalazion have very definite Demodex in play as well. So I do think there's a potential link between those as well. Oral treatment-wise, we tend to think about your tetracyclines, in particular doxycycline. There is a product called Rosacea, which is 40 milligrams of doxycycline. Why they did it as 40 is because they didn't want to do 50, because then people would have used a generic 50. We traditionally use kind of a generic 50 on them. Generally, you're talking probably several months in treatment. I just got an email from a former student saying, how long should treatment be? And we really don't know. It's going to be really kind of dependent on your patient and kind of where they're at in the management of their kind of condition with the doxy, and potentially pulling them off the doxy and kind of seeing what happens. So there was really no kind of hard and fast rules on how long a patient should be on doxy. Remember, we're using doxy as as a sub-antimicrobial dose. So typical killing dose for doxy is 100 milligrams twice a day. We're using this as 50 milligrams once a day. So what we're really doing is anti-inflammatory. It's not killing bugs that are there. And we really don't want to kill the bugs that are there, because then some other bug's going to come in and take over. So that means that you can actually keep these patients on this medication for long periods of time, because you're never going to actually get to killing doses. By acting as an anti-inflammatory, there's no real chance for them to develop resistance, because they don't ever get to the point where the bugs are ever threatened. One of the pharmaceutical agents that has the best evidence to show to get rid of the redness that people get with acne rosacea is actually a brimonidine gel. One of the brand names is called Mirvaso, and it works extremely well. The downside is that's cost. It's about $530, the cheapest I could find here in Portland. So it's a cost issue on this one, but if you have patients that are bothered by the redness, then Mirvaso could be a good option for them. Light-based therapies like IPL are actually very good for, in particular, the telangiectatic vessels that we find with patients with acne rosacea. So if you have access to IPL, I'd highly recommend that for the treatment of patients with rosacea. And we're kind of, the debate is whether or not the IPL is affecting the Demodex, or potentially there's bacteria that are on the Demodex that are causing this inflammation. But regardless, it's treating either one of those, and is really good for getting rid of those telangiectatic vessels. All right, so hordeola, these are basically styes. So they're infection of the meibomian glands, depending on whether or not they're an external or internal hordeola. We tend to see quite a few of these in practice. Patients come in with a swollen, tender lid. Again, showing you kind of the external kind of part to one of these and the internal bump that goes along with it. So my first question for you is, we have a 6-year-old, so I had a young male come in, 6 years old. His dad brought him in. This was the second or third time that I think that we saw him. And his dad says he's getting these styes fairly often. They're not always in the same spot, but they're really painful. They're already kind of doing some lid hygiene stuff, but want to know if there's anything else we can do to help treat or manage the condition. So again, QR code up to the right if you wanted to log in. All right, let's see what people are saying. So majority going with doxy. Next big group kind of between augmentin and azithromycin. And I'm going to tell you, I have a bias against doxy. I'm not a huge fan of doxy for hordeola. Because I'm in this lumps and bumps clinic, I see a lot of patients come in who have hordeola now developed into chalazion because they were put on doxy. And I'm sure there's lots of people that where doxy works, but for me, it's not my go-to. So I would much prefer augmentin. The amoxicillin I think is going to have a much better chance of getting rid of the bacteria that are there versus doxy. Azithromycin, we have to be a little bit cautious about that. It's got great dosing, but the downside is staph is becoming pretty resistant to azithromycin. So there's a high resistance issue with staph and azithromycin. And if we think about what's most likely cause for hordeola, it's staph. Tobradex then could potentially take care of any staphylophoritis that's there, but likely won't get into that gland and take care of the hordeolum. Vigamox, again, I don't think it's getting into the gland. And we really want to do the warm compresses and digital massage. But again, it might not take care of it. And they've already kind of been doing that, and it hasn't really taken care of him getting the styes. So which of the following statements with respect to the tetracycline group of antibiotics is incorrect? So which of the following statements is incorrect with respect to the tetracycline? And the majority of you chose A, B, C, D, E, and that actually is a correct answer. The incorrect answer is it has nothing to do with blood sugar levels. So the correct answer is actually C. So the incorrect ones, it has nothing to do with blood sugar levels. So doxycycline has been found to not have really an effect on discoloration of teeth in kids. Dentistry has known it for 30 years. They just didn't tell anybody else that. But there's recent evidence to show that you can use doxycycline regardless of age as long as it's less than 21 days. And I'm not saying willy-nilly prescribing doxy, but if you feel that you need to prescribe doxy, it doesn't matter what age the patient is, as long as it's less than 21 days. So with hordeola, warm compresses, I do think are a benefit for patients. If it's the first time hordeola, I will maybe try the warm compresses, but if they try them before, so me, warm compresses don't work, and I get styes fairly regularly. If I get a hordeolum and I do warm compresses, it's going to end up as a chalazion. The last time I had a chalazion, I allowed my third-year interns to practice on their injection skills on me. Yeah, that's not happening again. I ended up with a huge shiner. And the time before that, I had one of the faculty members do an incision and curettage on me, and I passed out in front of the students, which is so not good for my rep. So I don't want to do that again. So for me, it's oral antibiotics. We have to remember that internal hordeola are classified basically as a low-grade preseptal cellulitis. So we would never treat a preseptal with a topical or warm compresses. So if you think about the internal hordeola being a good chance for them to develop a preseptal from it, then we have to think that orals should be in the mix at some point. So I'm a big fan of augmentin, 875 twice a day. Keflex is commonly used. You're going to see TID to QID. I should really change that and just have it as QID. When it comes to Keflex, you really need to do the full dosing on it. The old Wills manual used to have it like 2 to 3 times a day, but there's now been some resistance issues, concern for resistance issues with Keflex. So the best way to do it is just dose it the way it's supposed to be. So 500 milligrams 4 times a day. So your side effects of your tetracyclines, so the gastric discomfort, phototoxicity, calcified tissues, vestibular problems, IIH. So traditional wisdom has that children under the age of 8 should not be receiving tetracyclines. And we've traditionally left the tetracyclines for the tick-borne diseases. So Lyme disease, Rocky Mountain spotted fever. It is actually now the new indication for the treatment of patients with chlamydial infections is 100 milligrams of doxy twice a day for 7 days. It used to be a single brand dose of azithromycin. It is no longer considered standard of care. It's actually doxycycline, the standard of care. Standard of care for gonorrhea infections is an injection of Rocephin, and that dose is doubled. It used to be 250, now it's 500. The gastric discomfort is absolutely going to happen if you don't recommend food with patients taking doxycycline. And the vestibular problems that we tend to see with the tetracyclines really are based around minocycline. Minocycline crosses the blood-brain barrier, so it has the chance to result in vestibular issues. Doxy won't do that. Here's that study which showed that patients under the age of, as long as doxycycline is used for less than 21 days, it doesn't matter what age of the patient is, you're not going to result in discoloration of teeth. Again, we've traditionally left them for tick-borne diseases, but if you feel that you need to prescribe doxycycline for a 6-year-old, then you can prescribe doxy for a 6-year-old. It is now also considered a standard of care for patients with the MRSA infection. Traditionally, it's been that if a patient has a MRSA infection and you wanted to use doxy or minocycline for it, you'd have to get it tested and find out it's a susceptible strain. But now, because we have the other alternatives for treatment of MRSA infections can have issues, they've moved doxy and minocycline up to first-line therapy for patients. Again, doxycycline is 100 milligrams twice a day for about 7 days. Minocycline, 100 milligrams, 200 milligrams for orally once, and then 100 milligrams orally twice daily. My rules of thumb for taking the tetracyclines, in particular doxy, is do not take before lying down, so at least 2 hours before you lie down. Do not take with calcium and avoid antacids. Magnesium can be in there too. They don't want to be taking any magnesium supplements because it could inactivate the doxy. You do not want to take with dairy. Dairy kind of coats the stomach and prevents absorption. You want to take it with food, absolutely, and recommend it's a sun sensitizer. So they have to have sun protection because it can result in significant burns. All right, we're going to switch gears here a little bit. We have a 13-year-old female patient presents with an acute onset swollen and painful lower lid. VAs are good. EOMs are full, though there's some discomfort on eye movement. Pupils normal. Patient has low-grade fever. Well, 100 degrees centigrade is not actually a low-grade fever. Other than your patient spontaneously combusting, I meant 100 degrees Fahrenheit, not 100 degrees centigrade, but 38 degrees centigrade. What's your diagnosis? All right, she said. So this is a preseptal. So I probably caught a few of you on the orbital cellulitis by the temperature. So crucial cutoff for between a preseptal and orbital cellulitis is 102 degrees Fahrenheit. That's your crucial cutoff. It also separates out between the viral and a bacterial infection. Remember that your patients with orbital cellulitis are going to have decreased VA. They're going to have proptosis. They're going to have an APD. They're going to be systemically sick patients. The dacryoadenitis is an infection of the lacrimal gland, which will be superior and not inferior. And an internal hordeolum is not likely going to take up the entire lid, and they're not likely going to have a temperature. I am going to ask you to look at this picture upper right, which is a preseptal, and tell me how you could tell the difference between that being a preseptal and being a dacryocystitis. And is it important to tell the difference between the two? Treatment's exactly the same, but why is it important we separate out between a dacryocystitis and a preseptal? Well, first of all, you identify it by pushing on it, right? The patient will not be happy you pushed on it, but pus will come out of the punctum. And why that's important is because there's a blockage in that system. So with the lumps and bumps clinic that I have here, I have a phenomenal oculoplastic surgeon that I work with, and he's the one who taught me this, saying, you know, Blair, if you ever have a dacryocystitis, then go ahead and treat it with your oral antibiotics. But once that's done, then send them to me, because I need to run a silicone tube through that system to make sure that it's patent and that it's open and they won't develop another infection. He said that there's enough inflammation from that actual infection to result in narrowing of that passageway and potential closure again. And traditionally, we think about DCRs where they make a cut. Well, what he does is takes a very fine silicone tube and he just runs it right through the system. So if you have someone who's had dacryocystitis, make sure you're identifying it, treat it the same way, but then send them to oculoplastics to have a silicone tube rubbed through. With preseptals, we're seeing most of them are probably coming from an internal hordeola that's fistula to the tissue that surrounds it. That infection inside that gland wants to get out of that gland. It wants to go somewhere else. So it's going to try to break out of that tissue and go to the tissue that surrounds it. I had a patient up in Alaska who had probably the largest hordeolum/chalazion I've ever seen. It looked like like it was a mouse running underneath his lid. He wanted an incision done. I said, great, let's do it. And as I was palpating him, he felt some tenderness. So I said, you know what, I'm gonna put you on an antibiotic for a week and then I'll see you back in a week and we'll do the procedure. But I flipped his lid over and it broke open and all this pus started oozing out. Well, if it had broken any other direction, now we've got a preseptal. So that's why I think we have to be a little bit cautious when we're telling patients to do warm compresses and digital massage. They don't get in there really hard and start pressing on it because it could break laterally. And now we've got a preseptal. So there's your differences between orbitals and preseptals. Again, your orbitals have an elevated temperature, so typically 102 to 104 degrees. They're going to have an APD. They're going to be proptosis, restricted and painful eye movement, where you don't typically see that with preseptals. All right, now we've determined our 13-year-old's preseptal secondary to a MRSA infection. With no allergies, what would you recommend for this patient? All right, so majority went with Bactrim, and I would say that'd be your correct answer. Remember, methicillin-resistant staph, anything in the penicillin family is not going to work. So Augmentin, which is amoxicillin, won't work. Caflex, which is part of the penicillin family, won't work. And I'd really like to see this final group just kind of go away and just disappear. First of all, you can't use Cipro for a MRSA infection. It won't work. Second of all, it's contraindicated in patients under the age of 18, so you can't even use it in that group. In addition to that, the FDA has basically come out and said, even if you think that Cipro is the best option, find something else to use. There's just too much side effect profile to the oral fluoroquinolones. It can result in rupturing of tendons. It can result in neurological deficits. It can result in seizures, changes in blood sugar levels. They have a pretty nasty side effect profile systemic-wise. Topical-wise, they're perfectly fine, but systemic-wise, you really want to use something else. In my mind, there's really not much reason for you to prescribe an oral fluoroquinolone in optometry. So my go-to is Augmentin, so 500 milligrams TID or 875 twice a day for 5 to 7 days. Adult prescriptions should be no longer than 7 days in length. If that infection is not taken care of in 7 days, then you need to switch them to something else. So don't give them a renewal of that prescription, but switch them to a different antibiotic. All you're doing is developing resistance at that point. Kids are still in that 10 to 14 day range, though I've read articles recently saying that kids should probably be in the same time period, should be in that 7-day time period. Again, if they haven't dealt with that infection within 7 days, then you need to switch them to something else. So Augmentin, this is amoxicillin plus the potassium clavionate or clavinic acid. Remember that your beta-lactam antibiotics, the active component to that antibiotic is the beta-lactam ring, and it sits up here. While staph has gotten really smart, it produces penicillinase, which is a beta-lactamase inhibitor, rips off that beta-lactam ring and inactivates the antibiotic. So what we need to do is keep that molecule intact. So by adding in the potassium clavionate to the mixture, it prevents that enzyme from working on the antibiotic and keeps it intact. Amoxicillin's got great soft tissue penetration. So we want to keep that antibiotic intact if we can. And what we need to do is just basically shut down that enzyme that's inactivating it. The potassium clavionate is a standard 125 milligrams, depending on, regardless of what dose you're using. So it's 250, 125, 500, 125, and 875, 125. Remember, that's just acting as an enzyme. It has no antimicrobial properties in and of itself. Really good for any soft tissue infections. So dactylic cystitis, internal hordeola, preseptal cellulitis is now considered standard of care for patients with an otitis media, so ear infection, as well as a sinusitis. Remember that 95% or more of your sinusitis are secondary to a viral infection. But I do think sinusitis are a highly overlooked reason why patients have, in particular, pain and ache behind their eyes. There's nothing back there but orbital fat. So if they're feeling a pressure and ache behind their eyes, it's coming from the fact that that space is filling up with mucus, which is coming from their sinuses. Typically worse on the side that they sleep on. Kind of a quick check on that one is if you give them Sudafed and it seems to get better, then you know that's congestion secondary to their sinuses. Very rarely do we ever actually have to give a patient who has a sinus infection an antibiotic because the majority of them are viral in nature. But I would make sure that you're not overlooking that as a potential cause for a red eye. In particular, if patients are feeling that they feel a pressure or ache behind their eye, it's likely sinus related. Antibiotic-associated diarrhea is a big concern, in particular with patients who are taking amoxicillin. Amoxicillin is a big player in antibiotic-associated diarrhea. And why? It's because it just basically changes the flora in your gut. The bacterial flora that's in your gut needs to be there. It needs to stabilize that whole GI lining and how your digestion and whole body works. But by taking an antibiotic, it's not specifically killing whatever bacteria you want it to kill. It's kind of non-selectively killing bacteria. And so therefore it changes the flora in your gut, and then, nausea, diarrhea, upset, that type of stuff can happen. So what you really need to do for any of your antibiotics, but particularly the amoxicillin group, is recommend a probiotic. 2 hours after, recommend that they eat a container of yogurt, which is what I typically recommend, or some other form of probiotic to start repopulating the gut's bacteria. Your patient's going to be really appreciative that you mentioned this to them. Again, not taking it at the same time, because at that point, the antibiotics going to kill whatever the probiotics are there. They're just going to kill them. So 2 hours after, make sure you're taking, say, the amoxicillin with food, again, to prevent some of the GI issues that go along with it. But then a probiotic 2 hours after. Typically, a container of yogurt has more than enough probiotics in there to start repopulating the gut. So what percent of the population has a true penicillin allergy? And the correct answer is actually A, 1%. Now, if you ask patients how many believe that they have a penicillin allergy, it's the final one, which is a 1 billion %, which some people chose. Everybody feels that they have a penicillin allergy, but having a true penicillin allergy, only 1% of the population has. In reality, 10% of the population believes they have a penicillin allergy, but in reality, only 1% does. And the CDC has come out a few years ago and said, again, 10% of the population believes they have an allergic response to penicillin and may have had in the past, but only 1% of the population truly has an allergic reaction to penicillins. When we think about penicillin allergies, we typically think that it happened as a kid. Well, after 10 years, 80% of those patients outgrow that penicillin allergy. So the recommendation is that anybody who reports a penicillin allergy, that you recommend that they get penicillin testing done, which can be done as a skin test in the office. What they'll truly do is actually then give them a solution that has the penicillin and cephalosporin potentially in it, then obviously have the ability to counteract any anaphylactic shocks. But then it keeps those group of antibiotics in play for us. There's a huge shortage of antibiotics, certainly, and a huge shortage of new antibiotics. And we really don't want to eliminate a group of antibiotics that's really beneficial and has a very low side effect profile for patients. I recently wrote an article on this, kind of addressing the whole penicillin allergy and recommending patients get penicillin testing done. One of the articles recommended that we direct challenge them. And I can't say that I'm overly curious to see what would happen if I say, oh, you had a penicillin allergy. You know what? Let me give you this and see what happens. And we'll just kind of figure out what happens to you. If you explode, you explode. So I don't think many of us would want to direct challenge patients, whether they're saying, unless there was truly a true anaphylactic response as a child, that if it was just mild hives or et cetera, that you can direct challenge them. Again, I probably wouldn't recommend that, but I certainly would recommend that they get the penicillin testing done so that if they don't have a penicillin allergy, then we can incorporate that back into their treatment. So again, my big favorite is Augmentin. That's the amoxicillin plus the clavinic acid. 250 milligrams is always TID, 500 is BID or TID, and then 875 is always twice a day. Again, exclusively pretty much 875 unless the patient can't swallow the pills. The 875 pills are huge pills, so you need to make sure that you can swallow them. Please don't recommend that patients snap pills or they crush them. In particular, if there's a clear coat on that pill, it's enteric coated, which means it's designed to be absorbed by the intestines and not the gut. Once you start changing absorption patterns, you start changing how they're broken down and how much actually gets into the system. You can see that I gave you the pediatric dosing there in the bottom. Not that I expect anyone ever to remember the pediatric dosing, but you can see that the dosing is 45 to 90 milligrams per kilogram per day, which means that there is a range still in play. So you can't just say, you know, I want this 6-year-old child that's this tall and weighs this much. I want them to have Augmentin. You still need to give them a dose on what you want to give. And that's equivalent to like having 500 milligrams BID or TID. Effectively, what you're doing is you're effectively almost potentially doubling the dose on them. So the pharmacist is still going to want to know what dose you want to give. Obviously, do you want to be in the high range or on the lower range? Your cephalosporins, these are closely related to the penicillins. They're part of the penicillin family. They're also referred to as beta-lactam antibiotics, which means they have the beta-lactam ring. So same mode of action, same resistance issues are in play. They come in 5 different generations. As you go up in generation, you go up in gram-negative coverage, and typically you usually go up a significant increase in cost as well. These medications are not well orally absorbed. Most of them are IV or IM. So for example, Rosacea, which is ceftriaxone, which is what we tend to use for patients with gonorrhea infections, that's an IM injection. But the big 3 that you want to remember are Keflex, Ceclor, and Omnicef. Keflex is 1st generation, Ceclor is 2nd, Omnicef is 3rd. Omnicef is no longer available as a brand name product, but it is available as a generic. Keflex being a 1st generation, cephalosporin, if you're going to have a cross reactivity between penicillins and cephalosporins, it's going to be 2 1st gens. So if you have any concern that your patient might have a penicillin allergy, then don't prescribe 1st gens. Don't prescribe Keflex. Do Ceclor or Omnicef. With Keflex, again, its dosing is 500 milligrams 4 times a day. I would highly recommend that you do that dosing. It's going to help prevent resistance issues. It's going to make sure there's enough antibiotic in the system. Yeah, it's more common dosing, but ultimately, I don't like to see it less than that because then I'm afraid that you're not treating the infection the best way you can, and we're increasing the chance for resistance. Ceclor, 250 and 500, typically TID. There is an extended release formulation, which I have to admit I haven't used, but generally we're thinking 250 to 500 milligrams 3 times a day. So Omnicef, no longer available in the US as a brand name, but it is available as a generic. I really do like this medication. Now that it's a generic, it's much more cost effective for patients. But this is one of the few medications where it comes in 300 milligrams capsules, and typically we'll want to say it's BID dosing. So once in the morning, once at night. It's one of the few antibiotics that you can give both capsules at the same time, and it's equivalent to giving them 300 milligrams every 12 hours. So for a dosing regimen, this is a great medication because you can just give both doses at the same time, and effectively you're done at that point. Bactrim Receptra, so 2 brand names for the same product. This is a combination of trimethoprim and sulfamethoxazole, so TMX/SMX. Both of these are sulfa-based products, which means that you can't have a sulfa allergy and actually take the medication. They're good for, chronic infections like UTIs and things like prostatitis is what they're used for. But they are also good for MRSA skin infections, and they are considered first-line treatments for MRSA infections. So Bactrim comes in 2 strengths. It comes in standard strength, which is 2 pills every 12 hours. And it comes in a double strength formulation, which is 1 pill every 12 hours. So you're going to prescribe Bactrim to a patient. Which of the following medications that a patient might be taking would be contraindicated to prescribe Bactrim to? So which of these medications would you never want to prescribe Bactrim to? Correct answer is B, is methotrexate. And why is because both methotrexate and your sulfa-based medications are folic acid inhibitors. And that's how they prevent bacterial growth, is by preventing folic acid from accumulating. Both of them can result in bone marrow suppression. So a combination of the two can increase the chance of bone marrow suppression and could result in death in patients. So really don't want to prescribe Bactrim to someone who's taking methotrexate, because it could be a really bad combination in shutting down the folic acid and also resulting in bone marrow suppression. Anybody who's taking methotrexate tends to take a folate supplement, because if they don't, they tend to get mouth ulcers. So if you ever see methotrexate on someone's medication list, look for the folate, because it's likely to be there. So a major contraindication is prescribing it to patients with methotrexate, again, for the potential for bone marrow suppression. Interesting enough, this is not talked about an awful lot with this group of medications, but they do have the chance for kidney stones. So you really don't want to be dehydrated on this medication, because it could dramatically increase your chance of developing kidney stones. And we tend to think about the tetracyclines as sun sensitizers. Well, this medication is as well. So they can result in reactions to the sunlight for brief periods, can cause sunburn, skin rashes, redness, itching, and discoloration. So kind of along the lines of doxycycline. And again, that's something that's sometimes commonly overlooked when people are told the side effect profiles for Bactrim, is that they want to be really hydrated and they don't want to have any excessive sun exposure. So there's your indications for the treatment of MRSA. So the big ones, Bactrim or Septra. Clindamycin. Clindamycin is not my favorite. It is actually indicated for the treatment of MRSA infections. The downside is it can result in pseudomembranous colitis, which means you could actually technically kill your patient. I'm just not really a huge fan of treating with medications that potentially could kill my patient. And the newest ones are doxy and minocycline. I like minocycline. I think it's a great antibiotic. The downside is I don't like the vestibular side effects to it. So a lot of us avoid that medication, but doxy is traditionally what we tend to use. All right. So those of you who know Dr. Tammy Thon, a very good friend of mine, brilliant optometrist. We gave a lecture at Academy a few years ago, and we entitled that lecture Facts or Fiction. And what we did is we polled the audience like we're doing right now, except I didn't give you the answers. So I'd say, how do you treat a recurrent corneal erosion? How do you treat a corneal ulcer? How do you treat a preseptal, et cetera? And then what we did is we went to the literature and said, what does the literature say is the best way for us to treat these conditions? Then we repolled the audience with the same question and said, did we effectively change your mind? And then we compared the pre and the post. And this is the case that Tammy had seen. As she was working in the VA in Georgia at the time, and as a patient that she saw. And I think it's got a really good example of something I'm not too sure that you guys are aware of, and something I want you to think about. So it's a 67-year-old female patient, comes in. She had seen Tammy basically 3 days previously. On that day's visit, nothing really unremarkable. But the next day, the patient started developing headaches, some vision loss, and now it's back to Tammy. So 3 days from the original exam. I think you can agree that this patient's got some visual field loss. Where's the problem? Well, there's your problem. The patient's had an occipital lobe stroke, an ischemic stroke. So what's your recommendation for this patient? All right, let's see what you said. So majority going with a baby aspirin. Next big one is educate patients nothing can be done, oral pred. The correct answer is actually D. It's minocycline. And most of you are going minocycline. That doesn't make sense, giving a patient an antibiotic for when they had their stroke. But remember that your tetracyclines do have anti-inflammatory properties. They do have potential for neuroprotective abilities. In this case, it has to be minocycline and not doxy, because remember, minocycline crosses the blood-brain barrier. So we have the ability to get that medication into the nervous system, which you wouldn't get with doxy. So why minocycline? Well, it does lower MMP9s. Remember, MMP9s are a very powerful proteolytic enzyme. They're also collagen reshufflers. So they are a good indication of inflammation. Minocycline does act to reduce inflammation. It reduces what we call microglial activation. And microglial activation is effectively like scar tissue. So if you reduce the amount of scar tissue that's present, then you're going to decrease the amount of scarring that's present. Nitric oxide producer, that's a free radical scavenger. And we know that free radical scavengers suck up all these kind of detrimental free radicals that can cause more damage. They inhibit what's called apoptic cell death. And apoptic cell death is, the way I think about it, is if you traumatize a cell, it just wants to die. It just doesn't want to fight for itself. So if we can inhibit that programmed cell death, then we're going to increase the amount of viable cells that could potentially recover. All right, so most of the literature is in neurology, and I'm going to talk to you about a couple studies, but this is kind of the big one. These patients who had an acute ischemic stroke, not necessarily hemorrhagic strokes, but acute ischemic strokes, would report to the urgent care or the emergency room within 24 to 48 hours for an assessment, and also be started on minocycline, 2 milligrams for 5 days. They were evaluated using the NIH stroke scale, which is that scale there to the right. And any additional check mark means additional points that are added to the score. So they have, best gaze, visual field defects, facial palsies, then it increases the score. 0 to 1 is considered normal or completely resolved. 2 to 7 is considered mild. 8 to 14 is considered moderate, and greater than 15 is considered severe. All right, so there's 3 different studies here. The one I'm talking about right now is that top one. And so in the minocycline group, they start off at 7.5 and 7.6 in the control group. So effectively into that moderate category. The minocycline group's given at 200 milligrams for 5 days. And you can see they're evaluated day 7, day 30, and day 90. At day 90 in the minocycline group, they dropped down to 1.6, so almost completely resolved, where the control group remained at 6.5. The second group, again, lower numbers are better. Started off at 2.8, ended up at 0.9, versus control started at 2.0 and ended up at 2.1. The last group, bigger numbers are better. Started off at 70, ended up at 95, 64, and ended up at 78. So we can see from neurology data that there is the potential for neuroprotection by doing minocycline. So how does it apply to the eye care field? Well, there's not a lot of clinical evidence to prove that it's beneficial, but there is one clinical case report, and that's this one. So a 77-year-old male patient had an occipital infarct, and you can see that there's the visual field defect that goes along with that. And he's listening to either a news report like an ABC or NBC or one of those, and he hears about this use of minocycline for patients who've had a stroke. So he goes into his optometrist and said, I want to try this. And kind of asked, are there any side effects to it? And they're going, well, no, unless you're allergic to minocycline, there's really no side effects to the medication. So they're given minocycline 100 milligrams twice a day for 5 days. And they're seeing back shortly after treatment and then a year later. So remember these visual fields. Here's them shortly after treatment. Here's them a year later. So now, did the minocycline cure him or clear it up? Maybe, maybe not. It could be just the natural, progression for this patient, but it's pretty suspicious that you're having such a huge change at 3-week time period from going from almost a complete loss of the hemifield to kind of just this partial loss. And then a year later, it's even better than that. To me, the real important part to this one is, in particular in Oregon, this patient doesn't have a driver's license. This patient does. All right, so you're going to ask me a bunch of questions. Let me anticipate some of those. You're going to ask me, what time period should it be introduced? And I'm saying as close to the stroke as possible. I've given this lecture a ton of times, and I've probably got a case folder of about 15 cases where doctors have sent me their patients with pre and post-op visual fields, like pre-administration of medication and then after, and showed improvement in visual fields. It's not always as dramatic as taking away a hemifield, but there's definite showing of improvement of visual fields. I do have one doctor that sent me a case at 6 months that she showed an improvement in visual field. I think that's highly unusual. This study, all these studies were done for 90 days. So I'd say it should be in within the first 3 months, but as close to the time period as the stroke as possible. You're going to ask about other conditions you might be able to treat. And the only one I can really come up with is ischemic optic neuropathy, because I do think it'd be beneficial, because I think those overlap in kind of how they present with these acute ischemic type events. You're gonna ask me, can you repeat it? And I don't have good evidence to show that you can repeat it. There's no evidence to show that you can't either. And by the way, of the 20, I don't know how many thousands of patients, not probably 20, but certainly 2,000 to 4,000 patients that you've treated with minocycline and stroke, not one patient got worse. So there's your risk to benefit ratio is great, because there's almost zero risk. Unless the patient's allergic to minocycline, there's no risk to the patient. You're doing it for 5 days, and then you're just looking for improvement. You're certainly not going to promise the patient anything and saying, yep, you're going to get all your vision back, but you're also not giving them any risk either. So again, unless they're allergic to minocycline, there's no risk to the patient. So I would just make sure that you are not promising anything to them and give it a shot. I mean, you're not going to hurt anything, certainly. Potential is that you can make it better. So again, 200 milligrams of minocycline for 5 days. If you want, send me an email. I'm happy to send you the articles that I have on minocycline. The interesting area that minocycline has been really used now in kind of neurological areas for TBI. They have potentially found it could potentially be neuroprotective in TBI injuries. I don't have a lot of information on that, but I do have some articles on it. So if you want, I can send those to you as well. All right, the last thing I quickly want to go through, and I'll very quickly go through this, is a patient I had probably 20 years ago now. 30-year-old Black female comes in complaining about pain in both eyes. It's gone on for several days. She's never had an eye exam before. In her medical history, she reports that she's had chronic bronchitis. She recently developed a rash in her legs, has recently lost weight, and has developed a fever. She's taking aspirin for pain. So with her entrance skills, 20/30 in both eyes, you can see that there's an anterior chamber reaction. There's KPs on the back surface of the cornea. We can see that we have an anterior and posterior involvement with the uveitis. So this is a granulomatous panuveitis. So granulomatous being the fact that it's both eyes, fat KPs, anterior and posterior involvement. And this, what you're seeing in the back of the eye is really what we would call a periphlebitis, which is probably really strongly linked into sarcoid. Sarcoid is going to be your most common granulomatous panuveitis that you're going to develop. But the two other ones that you have to eliminate are TB and syphilis. Those all result in systemic granulomas and are at a chance of developing a granulomatous uveitis. So for sarcoid diagnosis, remember the majority of sarcoid is pulmonary. And so what we're looking for on x-rays is granulomas in the lungs, and we're looking for hilar adenopathy. Those granulomas go right down the core. The other big one that we look for is actually serum calcium or 24-hour calcium levels, because they tend to be hypercalcemic, and ACE, angiotensin converting enzyme, elevated in about 60% of patients. Remember, this enzyme is actually produced in the lungs, and it's part of your angiotensin renin aldosterone system. And so it's part of your blood pressure regulation system. And it is elevated in patients who have sarcoid, but not TB. So TB granulomas don't produce ACE, just the ones with sarcoid do. So again, those radiographic analysis, you're going to see that the lungs should be black. There shouldn't be anything in them. But the areas that are highlighting are right down the core. We refer to that as hilar adenopathy. Syphilis. There are 5 stages of syphilis. Jeff, there are 5 stages of syphilis. They don't go in chronological order. Your primary syphilis, secondary, and tertiary do. Latent typically comes in between the primary and secondary stages. And then there's also neurosyphilis. In neurosyphilis, it can happen at either primary, secondary, or tertiary. It doesn't really make much difference when it happens. So typical that first presentation of the organism is in that primary syphilis when they develop a canker sore, which is typically tends to be painless. In the secondary stage, they're going to get rash in weird places, palms of their hands, soles of their feet, up their trunk or back. Tertiary syphilis is when they develop the gummas on their face and the potential cardiovascular issues that go along with it. In diagnosis-wise, we have two types of tests. We have a non-treponemal test and we have a treponemal test. In the non-treponemal tests, these are basically tests to confirm that there's potentially an infection going on. So it doesn't necessarily tell you that you truly have the treponema organism, just means that there's an infection on. So RPR, the VDRL, they are done to indicate that there's an active infection, but it doesn't tell you it's truly syphilis. And so what they do is actually a treponemal test. And this is actually a confirmatory test. It confirms that the organism is actually present. If you ever get confused, just remember that the treponema organism is in the name of the test. So the TPPA, which is the treponema pallidum test, or the FTABS, which is the fluorescent treponemal antibody test, these are confirmatory tests. These are reactive or unreactive. Then they go back to the non-treponemal test to actually use for treatment. And you want to see a 6-fold reduction in those titer levels. TB on the rise, and also multi-drug resistant forms of TB. Two tests, the PPD or the tuberculin skin test is done, but the IGRAs are done in patients where there's potentially the PPD could be confused. If they have come from a foreign country where they're likely immunized for TB, then they're always coming positive on that test, and they do an IGRA to confirm whether or not they've been immunized versus being truly exposed. When we talk about uveitis, kind of the big three areas that we talk about uveitis is, where is it located? Is it an iritis, iridocyclitis, posterior uveitis, or panuveitis? Then is the infection or the disease acute, chronic, and I'll throw in recurrent, and then granulomas versus non. Your complaints of photophobia, pain, blurred vision, again, doesn't really tell us much specifically other than the fact that those are there. But the one that you have to remember that does not present this way are your kids. The JIA patients who get a uveitis don't present with photophobia, pain, or blurred vision. So be very careful in your JIA patients. The recommendation from rheumatology is typically they're examined every 6 months to see if there's an anterior chamber reaction until they hit that 18 to 19 age range, where then they tend to go into remission. We know about cells and flare, potential synechial formation. Treatment-wise, our saying is hit it hard, hit it fast, right? So using something like Predforte, Durezol is another option for patients. Your cycloplegics, these are important for helping to reduce pain in patients. Also, they help prevent synechial formation. So remember, your cycloplegics work by, they're a passive dilator. In other words, they prevent the pupil from constricting down. If you want to snap synechia, put 2.5% phenyl in, because it actually pulls the dilators open and snaps the synechia. Home atropine and scopolamine are no longer available. So typically we're using either cyclopenolate or atropine. Prefer cyclopenolate just because atropine puts them into a locked state, which can result in synechial formation. When it comes to the orals, which is what part of this lecture is, when we talk about mild, like say a mild vitritis, on patients, we typically think, you know, if we're doing pred, about 20 to 40 milligrams for a mild, for a moderate, about 40 to 60, and then severe, 60 and above. I much prefer Medrol dose packs. Methylpred is a stronger steroid than pred, and it's got a built-in taper. So they come in 4 milligram tablets, and you can see here on this little blister pack, and it's got 6 pills the first day, then 5, then 4, then 3, then 2, then 1. And it actually even tells them specifically when they should be taking it. So take these 2 tablets before breakfast, etc. The fact that it's got a built-in taper is great because then you don't have to taper the actual pills by snapping them. Remember so there's your kind of dosing. There's the initial dose, 20 to 40 for mild, 40 to 60, and then above 60. Remember your side effect profile to your steroids. They can affect every receptor in your body. What I do find interesting is the emotional disturbances. Traditionally, low-dose steroids tend to make patients really irritable or bitchy, which is what we tend to think about them. But you actually can go higher doses and kick into a euphoric state. So when I was up in Alaska, we had a young girl that we diagnosed with VKH. And so she was probably 80 pounds soaking wet. They put her on 60 milligrams of oral steroid. So big dose for someone who's so tiny. The next week I saw the mom in clinic and I said, so how's your daughter doing? She's so much better. Her vision's getting better. They're thinking about tapering her off the steroid. And I said, oh, has there been any side effects to that steroid? And she goes, well, like what? And I said, well, kids typically get, or people tend to get really kind of bitchy and irritable. She goes, first of all, my daughter's 13. I went, okay. And she said, no, she was actually lying on the ground laughing hysterically for 2 days. High doses kick you into a euphoric state, which I didn't know until that example. But remember, side effect profiles to your steroids, every cell in your body is going to be affected by them. And I think that's it. Remember tapering your steroids as well. Make sure you tell your patients you're going to wean them off of the drops and the orals if you're using them. NSAIDs do not play a role in the treatment of uveitis. Follow up every probably 1 to 7 days, probably every 2 to 3 days would be kind of useful.